Howdy. Today's seminar, entitled Nutritional Interventions Against Ocular Disease, will be presented by Dr. Paul S. Bernstein. Dr. Bernstein is visiting Texas A&M from the University of Utah School of Medicine, where he serves as adjunct professor of pharmacology and toxicology and professor of ophthalmology and visual sciences at the John A. Moran Eye Center. Dr. Bernstein graduated summa cum laude from Harvard University with his Bachelor's of Arts in Chemistry. He stayed at Harvard to earn a Doctorate of Philosophy and Pharmacology and Doctorate of Medicine from the Division of Health Sciences and Technology, a joint program between Harvard Medical School and the Massachusetts Institute of Technology. After earning his MD PhD, he interned in internal medicine at New England Deaconess Hospital in Boston, Massachusetts. Next, he moved to California, where he completed a postdoctoral fellowship in cell biology and residency in ophthalmology at UCLA Medical Center. Thereafter, he moved back to Boston, where he completed a fellowship in vitreoretinal surgery at Massachusetts Eye and Ear Infirmary. Dr. Bernstein currently divides his time between clinical practice and basic science research. He has been named one of America's best doctors annually since 2006. His laboratory is funded by the National Eye Institute and focuses on research within the areas of lutein and zeaxanthin activity and uptake in the macula. He has published more than 100 peer-reviewed papers and is co-inventor of non-invasive instruments that measure the nutritional status of the human eye and other tissues. Dr. Bernstein also gives an annual guest lecture to the Texas A&M class, Phytochemicals in Fruits and Vegetables and Human Health. We would like to thank Dr. Bernstein for speaking with us today, and please join us to give him a warm welcome.
All right, thank you very much for inviting me here. This is obviously my first trip down to this part of Texas, and I've been, Dr. Patil has been a very, very gracious host, and I've enjoyed my time here. I've had a long history in nutrition and in botany and phytochemicals. My PhD work was on vitamin A metabolism in the eye. That's how I became interested in eye research. I still actually I have a greenhouse and I collect trees as a hobby of all things. And I have some very rare trees from Australia, things such as Wollemi pine and bunya trees. So I've been, it's very close to my heart, and I've been studying. I'm going to be talking today about my work on lutein and zeaxanthin, carotenoids that are naturally found in the eye. I'll touch a little bit on omega-3 fatty acids also, but in the interest of time, we'll be focusing mainly on the carotenoids in the eye. And can you see well enough, or should we turn down some of the lights? It seems maybe a little bright up here. Yeah. Maybe the other way around. That's probably pretty good. Okay. So since you are not an eye institute by any means, I'm going to start with some of the very basics of what the structure of the eye and what is the macula and what is macular degeneration. So some of the things that I do from day to day. And this is a cross section of the eye, slicing right through it. And as you're all familiar with the front part of the eye, which is the cornea, the clear part of the eye, and the anterior chamber, which is the fluid-filled part of the eye right at the front. The cornea continues on to the white part of the eye, known as the sclera, shown here. That's the white coat of the eye. Next, when light comes in, it's refracted and focused partially at the cornea, and then in a more fine way, it's refracted at the lens, which is shown right here. And the lens is suspended by what are called zonules that hold it and allow it to change shape a little bit to allow the focus of the eye. And as the light passes through, there's an aperture here, the iris, the colored part of your eye. And then it enters the back part of the eye, which is my area of expertise. We're all very specialized at the Moran Eye Center, so I don't do anything. I don't do refractive surgery. I don't do cataract surgery anymore. I take care of the back part of the eye. And the back part of the eye is filled with the vitreous gel. And that's a clear gel that stays, that's found when you're born, and it doesn't turn over. So if you ever remove your vitreous, as I do sometimes in surgery, it just fills with a liquid part of the back of the eye. But the most important part is the retina here, which of a film type camera, this is essentially the film, or the light detectors are all lining along the back here. And that covers about the 80% of the back of the eye is the retina, and it has blood vessels coming in, arteries and veins here that come in through the optic nerve. But we only use a small part of our retina for the most acute vision that we have, the ability to read, drive, recognize faces. And that part is located right here, centered on the fovea, and it's a region that's only a couple millimeters across called the macula, right here. So this is the area, as we'll see in some of the next slides, that's filled with cones. So that's responsible for your color vision, your ability to see 20/20, basically best refracted. If you lose your macula, you lose your central vision, but you preserve your side vision here. The rest of the retina we use for seeing off to the sides so that you don't bump into things and so that you can see in dim light. But it's not involved in the high focus activity. And the area that I specialize in, not only do I specialize just in the back of the eye, but my area of research work is really focused on the macula, the center 4% of the back of the eye. And that's shown, and then the information from the retina is then gathered together, goes through the optic nerve, and then goes on into the brain. This is what the back of the eye looks like when you go to an ophthalmologist and they dilate your eye and you look into the back. Again, you can see the optic nerve right here, and this is only about 1.5 millimeters across, so it's very small. And from that comes out the blood vessels, the arteries and the veins come here, and they spread out across the back of the retina. But as you can see here, what we call the arcades, this area here is relatively blood vessel free. And the area that I'm outlining from the superior arcade here to the inferior arcade right up to the optic nerve is the macula itself. And right in the center is the fovea. And so if this is 1.5 millimeters, you can see that this really is about 5 millimeters across for the macula. And in the macula itself, or in the retina is a complex structure that has many different cells in the back. And so the light comes in through the vitreous, it's been focused at the cornea and the lens, comes into the back of the eye, passes through a series of cells, and eventually gets to the receptors at the back. These are the rods and the cones that you've probably heard about. The rods are what we use to see in dim light. That's what we use to see on, if you go into a movie theater, or if you go out at night, your vision is not very good, but you can see off to the side and you can kind of navigate around. But you also have cones here, and the cones come in 3 different varieties. They come in red, green, and blue, and that's shown here. They're each tuned to a different wavelength. And each of these wavelengths are shown here in the visible spectrum. You can see rods are tuned to about 500 nanometers, just into the blue-green here. But we also have blue cones here, green cones here, red cones here at different wavelengths, 400 some, 600 at 530, and then off into the red right here. If you have the cones, if you have all 3 functional cones, the blue, green, and the red, that's all you need for color vision. Just like on a CCD chip, you need 3 different channels, and that can put together all of the color vision that we have. The problem is that in about 5% of males, they're missing, or there's a problem in the red and the green cones, and that's the origin of color vision deficiency. But the cones they're not evenly distributed the way they appear here. They are much more focused right in the macula. And this is a cross-section through the macula of a monkey here. The vitreous side is down. The top part is up here called the retinal pigment epithelium, in the back of the eye is up here. So light comes in from this direction. And right in the fovea, the retina gets very thin here, what's called the foveal pit, where the cells move off to the side that allows light to go to reach the photoreceptors back here even better. In the center, right in the fovea, it's nearly 100% cones. That's where everything is concentrated right there. There are very few rods, but very quickly as you start moving away from the center, the rod cells take over, so they're 90%. And you've still got cones all the way off to the edges of your retina, but not nearly as many, and that's shown here. So there's a lot of structure to the back of the retina. It's very topographic in terms of how it's set up. And that will come into play when we talk about the carotenoids of the retina, the lutein and zeaxanthin. Within the rod cells themselves, they have an interesting structure where the light detecting proteins are all located in what's called the outer segment, and that's shown here. And it's a stack of disks of membranes, and in the membranes is a protein called rhodopsin. 90% of the protein is this one protein called rhodopsin, and it has on it the first phytochemical we'll be talking about, vitamin A, 11-cis vitamin A. So we get vitamin A from our diet or from beta carotene, its precursor. And it has a special form of retinal, 11-cis retinal here, that's bound to the protein, and it's ready to absorb light. If it absorbs light, and especially in a rod cell coming in at 500 nanometers, it then is converted from the 11-cis form, this high energy form, to the all-trans form, and then that activates a whole transduction cascade. And it's one of the original G-coupled proteins. I don't know if that's familiar to you or not, but that's how it does. It does a whole cascade. So it's similar to the beta receptor and other receptors, but its ligand is light, not instead of some other molecule there. So that's the basis of vision and how vision occurs in the eye. So that's kind of the background of some very brief, in 5 minutes, the physiology of a normal vision in the eye. And as I pointed out, vitamin A is one of the first important nutritional chemicals in the retina. But there's many where it does play a role in the eye. And it can range from the front of the eye, the cornea and ocular surface. Vitamin A deficiency can cause dry eye. It's one of the leading causes of severe dry eyes, enough that it can cause corneal scarring. It's one of the leading causes of blindness in the developing world. It's less involved in some of the other structures, the ciliary body, iris, and lens and optic nerve. But really, nutrition is very, very important in the retina, and that's what I'm going to be focusing on in my talk today. So there are many conditions that phytochemicals can play a role in retinal disease. And they can, and as we'll see in the next slides, we'll talk about night blindness, retinal degenerations, macular dystrophies, nutritional maculopathies, and then we'll focus a lot on age-related macular degeneration, which is my area of research work. So I mentioned about vitamin A, and it's long been known that vitamin A is very important, that some nutritional factors are very important for the retina. And this dates back to the time of the Egyptians, actually, or even before, where it was realized that certain dietary factors can treat a condition known as night blindness, the inability to see at night. And it turns out that they were recommending things like liver that are high in vitamin A and other compounds. And so they didn't know what was in there, but they were realizing that could be an important treatment for this. And vitamin A deficiency is very common in the developing world. It's not very common in the United States. It's really rare. I see it only 1 or 2 times a year in my practice in Utah, and it's mainly people who have had nutritional deficiencies related to poor absorption from the gut. They've had either gastric bypass surgery or they have some sort of liver problem. So there has to be some underlying reason, because it's too easy to get vitamin A in our diet here in the United States. In the developing world, it's a completely different story. It's one of the leading causes of preventable blindness. And we know that by giving just a dose or two, we're talking about once or twice a year of high-dose vitamin A, can replenish someone's stores and prevent night blindness, not only night blindness, but also prevent the cornea problems that can occur. When people do have night blindness, they develop these little white spots in the retina. We're not quite sure what they are, but this is one of the signs that we see here in vitamin A deficiency here. And the reason this happens is, as I mentioned in the visual cycle, vitamin A is very, very important. It's the key molecule on your rhodopsin protein that's absorbing light. And whenever you bleach your rhodopsin, and it's triggered, it's now in the low energy form, the all trans form. It then has to transfer to another cell in the body called the retinal pigment epithelium, be isomerized back to the vitamin A, to the active 11-cis form, and go back to the retina. And if you don't have enough vitamin A, this cycle just falls apart. So that's why you can't see. And this is very reversible if we do recognize this and give the prompt supplementation. The other things where nutrition seems to be important is a disease called retinitis pigmentosa. And that's shown here, where you see all these bone spicules, what are these pigmentation clumps in the retina. And this is a disease that's relatively common. It affects about 100,000 people in the United States. And it's related to various defects, usually in rhodopsin, the molecule rhodopsin, that disrupts in many cases, disrupts the vitamin A cycle. So the symptoms are very similar to vitamin A deficiency. You get visual field constriction and you get night blindness. That's the first thing they complain about. And it's been, I think in the next slide here. So one of the treatments that we do, although it's not a great treatment, is to supplement with vitamin A to try to improve the visual cycle in these patients with retinitis pigmentosa. And the dose that we give is pretty high. We're talking about 15,000 units a day. And this can slow the progression of retinitis pigmentosa, but it's right at the levels that are close to toxicity. So if we're giving this dose of vitamin A to patients, we have to test their liver function and make sure that they're not developing any problems. Also, in women of childbearing age, there's a very high risk of having birth defects also. So we're very careful about recommending this to women in childbearing age. Other studies, we've also looked at other nutritional approaches to this disease, including omega-3 fatty acids. They also help, but the effect is pretty weak. And also people have been looking at through the years whether lutein, which I'll discuss in some of the future slides, whether that could be helpful too. Because it seems that the levels of lutein are just a little bit low in these patients. And it's hoped, and since it is such a safe compound to use, that's one that we've also been looking at. But you have to be careful in what you give patients. More is not always better. And there are other diseases that can also cause diseases similar to retinitis pigmentosa, where there are certain compounds that actually make things worse. One of the classic ones, although it's an extraordinarily rare disease, because in my career, I've never met anyone with Refsum disease. But Refsum disease is a disease where phytanic acid, which is an unusual branched fatty acid here, accumulates in the retina and causes a lot of degeneration. And it causes something that looks like retinitis pigmentosa. And the way that it's treated is with a diet low in phytol and phytanic acid, and that's shown here. And you essentially have to eat no green leafy vegetables, and you have to have no animal fats and no milk products. So those of you who are into nutrition, what does that leave you with? It doesn't leave you with much, right? I think you can eat grains is about all that it is. And hopefully you're not gluten intolerant or something like that, and then you'd have nothing to eat. So the other disease is something called gyrate atrophy, and this is a defect in ornithine metabolism. And again, this is treated, you want to have a diet that's low in ornithine, and that's treated with a low protein, low arginine diet. With regard to the macula we're worried just about the center of the retina here. And there's a disease called Stargardt disease, where you get these yellowish spots, not quite as round as the ones with vitamin A deficiency. These are what are called flecks. And in this disease here, there's a loss. The peripheral vision stays just fine. The peripheral retina is okay, but it happens right in the center here. You can see the thing, for those of you who can see here, there's a little bit of just pigmentary abnormalities in this area. And a patient with Stargardt disease develops this problem at a young age, typically in their teens or 20s. They lose their central vision. And it turns out that nutrition is very important, both in a positive and negative way for various forms of Stargardt disease. Stargardt 1, which is the common form, which is recessive, is caused by a defect in the ABCA4 gene. And in that gene is involved in moving vitamin A in and out of the cells. And if that doesn't work, as we'll see in the next slide, vitamin A accumulates in the wrong parts of the cell and starts causing a lot of damage there. The other form is Stargardt 3 that looks the same but has a completely different mechanism, and that's involved in DHA and EPA, omega-3 fatty acid metabolism in the retina. So how do we intervene against Stargardt disease? Well, it turns out that unlike retinitis pigmentosa, where we want to give high doses of vitamin A is actually toxic to the retina in a Stargardt patient. And so we've been trying to figure out ways of preventing buildup of vitamin A, because when you have too much of the vitamin A hanging around and not moving properly from cell to cell, it starts reacting with the lipids of the retina, especially phosphatidylserine here, and that forms a compound called A2E that's shown here, and that's toxic to the retina and causes problems. So one of the ways that we are trying to treat Stargardt disease is prevent this formation, and using either vitamin A restriction or modifying the structure of vitamin A, we're trying to slow down the visual cycle and stop the formation of this. So that it's very important to understand, recognize, diagnose these diseases, understand the biochemistry, and we can kind of customize nutritional recommendations. So you wouldn't want to misdiagnose a Stargardt patient as retinitis pigmentosa and put them on high-dose vitamin A, because you would actually end up making them worse. The other form of Stargardt disease is a mutation that's involved in lipid metabolism. I'm sure a lot of you are familiar with EPA and DHA, which are lipids, common lipids in our diet that we get from fish oil, and they're incorporated into the retina. They're some of the very important fats that are part of the retina. But they're not the only story. It turns out that some of these lipids can be made much longer than 22 or 24 carbons, and they can go on to what are forming the very long chain fatty acid series shown here. And it turns out that in patients with Stargardt disease, ELO-VL4 is defective. They don't make any of these lipids, these very long chain lipids, and that affects the structure of the retina, and the retina becomes unstable and starts to fall apart. So we have a trial. I have about 18 patients with this rare mutation here, and I've just completed a trial where I followed them for 7 years and had them take fish oil, because we found in that family, some people did not have much of the disease, and it turned out those were the ones who were the fish eaters that were somehow bypassing this process, and that allowed them to have better vision. And so we're just analyzing the data now, whether 7 years of fish oil supplementation can make a difference. But as with any macular problem, just like retina problems, having too much of compounds can also cause problems. And one of the notorious ones is a compound called canthaxanthin, and that's shown here, where people were taking it because even though it was a natural carotenoid, they would take high doses, sometimes 4 grams a day. And they were doing that because it would give them a nice suntan, or a simulated suntan. It would turn their skin kind of a bronze color. The problem is, so much of it was getting into the body that it was also actually crystallizing in the retina, and that's shown here in a ring-shaped pattern. These are all crystals of canthaxanthin here. Fortunately, you can see the macula is relatively preserved. It didn't crystallize so much in the macula here. So these patients could still see well. They didn't have many visual complaints, but we never like seeing such a high dose that is actually crystallizing. It's probably not good in the long term. So this is a disease where we have at least tried to get canthaxanthin off the market, but it still is available right now. It's used as a food coloring. It's used in fish food. It's found in our diet, but not at such high doses. Other problems can come from oxalic acid. If you eat too many green leafy vegetables, and if you have certain genetic mutations, the green vegetables, the oxalic acid can crystallize in the retina, and that's shown here, called oxalosis. And having too much niacin, vitamin B6, even though it's a vitamin, if you take it at high doses, can cause, which they sometimes do to lower cholesterol, it can cause swelling of the retina, which is shown here. So the main theme that I'm getting at is more is not always better, and you have to at least make sure that the safety of your compounds is good. So that's kind of the background of other retina diseases. Now we'll concentrate on macular degeneration and the nutrition, how nutrition can affect macular degeneration. So macular degeneration is a very common disease. Unlike Stargardt disease, which affects maybe 25,000 people in this country and is inherited, macular degeneration affects literally millions of people. It's the leading cause of irreversible blindness in the United States and in the developing world. In the rest of the world, in the developed world, in the developing world, cataracts are much more of a problem. Depending on how you define age-related macular degeneration, somewhere between 1.7 and 20 million people have macular degeneration, and about 200,000 people have the advanced forms, new form of the advanced forms of macular degeneration each year. It's a relatively uncommon disease in people in the 50 to 60-year-old range, but it rises off actually almost exponentially once you get past age 75, so that about 30% of people over age 75 have at least some form of macular degeneration. It comes in two different forms, what's called the dry form, which happens in about 80 to 90% of people, where it starts relatively asymptomatic and then progresses slowly over years, if not decades, to slow loss of some of the cells of the macula, to the more abrupt form called the wet form of macular degeneration, which affects only about 10 or 15% of patients. But in that process, new blood vessels start growing underneath the retina. They bleed, they leak fluid, they cause a lot of damage that can occur over a matter of days, weeks, or months. It happens much more abruptly. And up until we started developing some new treatments for this, it caused 90% of blindness. That number is now starting to drop, so we're now having to deal more with the dry form of macular degeneration rather than the wet form. And this shows here just how it increases with age. This is women over here, and it's a disease primarily of Caucasians, Northern European Caucasians here. You can see it's only a couple percent, very small percentage, but once you get past age 75, it just starts rising dramatically. At least on this slide, it's estimating at least 15% of people who are 85 or older have macular degeneration. It rises a little more steeply in females than in males, and that's comparing this slide to this side to this side. And then you can see it's less common in Hispanics and blacks too. So the more darkly pigmented you are, the less likely you are to have macular degeneration. And macular degeneration causes loss of central vision, not the side vision, and that's shown here. So this is a classic picture from the National Eye Institute showing what a normal vision would be like, looking at two kids holding two balls right here. But if you lose your vision in macular degeneration, you lose just the central part of your vision, but this is the part that you need to recognize faces. So you get this grayed out area right in the center of your vision. The way I have some people simulate it is close one eye and hold your fist a few inches out in front of your eye, and you look straight ahead. And if I see a person out here, like if I'm looking at Dr. Patil, I can see that he has a head there, but I won't see his name. I can see that, but not his face. I can see his body, but I can't see right in the center. I can then use my side vision and see there's a person with a body there, but I can't recognize who that is because I'm using my side vision. And it's very frustrating to patients with macular degeneration because their central vision is blocked. They try to use their side vision is no good. So you can see it's very, very much a problem, especially if it affects both of your eyes. So in this simulation, you can't even tell that there are two kids here. This could be one kid holding just two balls there. And this is what macular degeneration looks like. In the dry form shown on the bottom, it may start out totally asymptomatic. The patients may see 20/20, they have no complaints about their vision. But we as ophthalmologists look in and we start seeing these yellowish spots shown right here. And this is what's known as drusen. And these are yellowish accumulations of oxidized proteins and lipids. And if dry macular degeneration progresses, eventually you lose the photoreceptors right in the center. And this is what's called geographic atrophy. This is the end stage of macular degeneration right here of the dry form. Progression from here to here to here could take 20 years, but people are living longer and longer in the United States. So that's why we're getting more and more people with this, having to struggle with dry macular degeneration. For the wet form of macular degeneration, you go instead of going along this path right here, we go upwards this way, And you can see the drusen are still here, but now the patient is starting to develop some bleeding. There's an abnormal blood vessel in this area here. You can't really see it because it's deep underneath the retina. But that's bleeding, and if it continues to bleed, you get a massive amount of blood underneath the retina. That's right here. And that, if left alone and not treated, will eventually just end up giving a fibrotic scar right in the retina. And again, both of these patients here would be expected to have worse than 2200 vision. That means that they would be struggling, if they're lucky, to be able to see the big E on an eye chart. And no matter how much you change their glasses or anything else, they still can't see anything better than that. So that's what's called legal blindness, if that happens in both of your eyes. And this shows in a cross-section image what actually is happening underneath the retina. Is the blood vessels that live underneath the retina are supposed to stay on this side of this barrier here called Bruch's membrane. But they break through and get underneath the retina and blister it up. And that's what the wet form of macular degeneration is. When someone has problems with macular degeneration, the first signs that they have is first that they may lose their visual acuity. They don't see 20/20 anymore. Or that things start to become distorted here. So if they looked at what's called an Amsler grid, which is just a very fine checkerboard here, the lines start to become distorted. They start to blow up or change here. And so that's one, they can monitor this at home and see if lines no longer are straight. Then they'd come in to see me as an eye doctor. We then do studies called fluorescein angiography or ICG angiography to look for these blood vessels. And we do optical coherence tomography, which are cross-section images of the retina. And we can localize these blood vessels. In the old days, we would treat these blood vessels by zapping them with a laser and essentially try to close them down. The problem is that there was a lot of collateral damage. We would cause scarring and actually make their vision worse than they walked into the office, but with the hope that this was going to be better than letting the natural history of the disease continue over the next few years. This obviously was not a very popular treatment. And we developed new treatments where we used lower power lasers or radiation to try to decrease this problem, but they still didn't work very well. They were better than the natural history, but they still caused damage. They didn't improve the vision. And then we even tried removing the vessels. We would get underneath the retina and try to do surgery to pull out these abnormal vessels. We tried transplanting cells underneath the retina. We did gene therapy. We did what's called encapsulated cell technology, where we put cells that would secrete growth factor in a little capsule in the retina here, and that would then help the retina stay a little bit better. Or eventually we would then use, and then we've even tried to develop artificial vision, but none of these worked particularly well. It wasn't until we got the new treatments where we injected medicine directly into the eye to combat the growth of these blood vessels. And that's shown here, the method where we would take a very small needle, a 32 gauge needle, and inject medicines in the eye that biochemically blocked the stimulus to send these new blood vessels in. And this is now one of the most common procedures that I do. I do probably 40 or 50 injections per week into patients. And the problem, the good news is that these drugs work very well. The problem is that they have to keep being given. Sometimes every month we have to keep giving them. And some forms of this drug, especially Lucentis, Lucentis and Eylea, cost $2,000 a dose. So you can add that up, how much that is. That's a lot. It costs $20,000 plus per year to maintain the person's vision per eye. So that's a significant problem. And we're trying to get longer acting drugs, better acting drugs than this. The other form of, so we've made a lot of progress against macular degeneration, but clearly we should be trying to prevent this problem. And so we've had to learn through the years what are the risk factors and how can we manipulate these. So there's many things that drive our risk of macular degeneration. We've already talked about age. That's the older you get, the higher your risk of macular degeneration. The second thing is heredity. It runs in families, and we know that we know some of the genes that are very important for macular degeneration. And that accounts for almost 50% of your risk of macular degeneration. Is just what you've inherited from your parents in terms of the risk factors. But these are all risk factors. It's not a true Mendelian disease, where if you have a risk factor, I say you're going to get the disease. That's something like retinitis pigmentosa or Stargardt disease. This is more like high blood pressure, heart disease. It's many different genes coming together combined with the environment. So just because you have the high risk doesn't mean you're necessarily going to get it. It just means that you have a higher risk of getting the disease. We know it's a little more common in women than men. That's a pretty minor risk factor. We know it's more common in lightly pigmented individuals, but none of the things here are particularly modifiable. The ones that we concentrate on from a public health standpoint are the modifiable risk factors. And they range from smoking, which we know is a very high risk factor for macular degeneration. And so, of course, we recommend that people don't smoke. Cardiovascular disease, risk factors, blood lipid status, and high blood pressure is important. Alcohol consumption, just like in heart disease, small amounts of alcohol might even be a little bit protective. We think that light exposure, excessive light exposure, is a risk factor for macular degeneration, but it's hard to quantify how much that really is, how much light we're really exposed to. It's really in the extremes that we see that being a risk factor. Other risk factors include nutrition, and nutrition is a risk factor that is that we're going to be focusing on next. So why is nutrition important in the retina? Well, the retina has a lot of lipids. These lipids are very unsaturated. They're very susceptible to oxidation and light exposure and excessive light exposure. So it makes sense that age-related macular, if we assume that age-related macular degeneration is a disease of oxidative stress, it makes sense that antioxidant type nutrients may be important. But this is a difficult studies to do. I know a lot of you are interested in nutrition. These are free-range individuals. You know, we eat a lot of nutrients in our diet, and these are, so it's very hard to sort this out. It takes large studies to prove that macular degeneration does make a difference. So how do we approach identifying nutritional risk factors for macular degeneration? Well, some of it is done by epidemiology, taking large groups of patients and seeing who's eating, who have macular degeneration and who don't, comparing their nutrient intake and trying to figure out which are the risk factors. This gets us associations, but it won't prove cause and effect. But we then have to prove that in further studies, including animal studies, but the animals don't get macular degeneration, at least not the same type that we do, so that's difficult. It's important to do the physiology, and that's one of the specialties of my laboratory, in that the nutrients should be found in appropriate quantities in the retina, and the physiological mechanisms should be plausible. That's what we're trying to show. If it's an antioxidant, if you think it's an antioxidant, you should be able to prove that it has antioxidant capacity. And it'd be nice to be able to show that deficiency states might be associated with higher risk of macular degeneration. And eventually we want to do prospective clinical trials to prove that to actually get clinical practice to change. So through epidemiology, we've seen that there are many different factors that may be important in protecting against macular degeneration. Some of the early studies pointed that antioxidant minerals such as zinc and selenium may be important. And so zinc has been studied quite a bit. These are cofactors for a number of different antioxidant enzymes. The usual antioxidant vitamins, the common ones, vitamin C, vitamin E, and vitamin A, have been looked at. Polyunsaturated fats like DHA and EPA could be very important because they're a third of the lipids of a rod outer segment are DHA and EPA. And then the carotenoids lutein and zeaxanthin are very important, and that's going to be the focus of the rest of this talk because they're consistently concentrated in the eye at very, very high amounts. And then at the end, I'll talk a little bit about herbals and other less defined protective factors. So our current, up until recently, the current way that we approach nutritional interventions against macular degeneration was based on the first very large study that looked at nutrition. And this was called the Age-Related Eye Disease Study, or the ARED study. And this was done by the National Eye Institute and studied nearly 5,000 subjects, 55 to 80 years old, and they were followed for at least 5 years. And they were randomized either to the best antioxidant combination that they could think of. But you have to remember, this started in the late 1980s. So this was the nutrition knowledge of the late 1980s. And so they left out some key things that we've learned may have been important, such as lutein and zeaxanthin. And they looked at the incidence of cataracts and severe vision loss from macular degeneration. And they concentrated primarily on the higher risk patients, so people who had the yellowish spots, the drusen, or had already started to form some early geographic atrophy, or they looked at people who had already lost one eye to advanced macular degeneration. So we knew the second eye was going to be very, very high risk. And the formulation that they came up with looked at 80 milligrams of zinc oxide, 2 milligrams of copper, because this 80 milligrams of zinc was so high that this would induce anemia, so you had to add 2 milligrams of copper. Then we also looked at vitamin C and vitamin E at pretty reasonable doses, 500 milligrams and 500 milligrams of vitamin C and 400 international units of vitamin E. And then they picked one carotenoid, beta-carotene, but it turns out beta-carotene was not the greatest choice. One is it's not naturally found in the retina. It's actually broken down elsewhere in the body to vitamin A. And so, and they didn't know much about lutein and zeaxanthin, so they chose this one anyway. And then they first looked at the risk of cataracts. You can see there was no difference whether you were assigned to the placebo arm, to the antioxidants arm, or the zinc arm. So there was no difference. But in the looking at macular degeneration, there was a definite difference. You were worse off if you were in the placebo arm. You had a 40% chance of having advanced macular degeneration after 5 to 7 years. But if you were in the arm that got everything, down here it's shown in red, that decreased your risk by about 25%. Doesn't sound dramatic, but if remember, we're talking about a disease that affects millions of people in the United States. So if you can cut that rate by 25%, that's a big deal. So this changed practice very quickly in that we started anyone who had the intermediate to advanced stages of macular degeneration, we started them on these antioxidant supplements. But this was just the first step. Just like cancer chemotherapy, we weren't done. We had to improve this. And by then, there was new knowledge that lutein and zeaxanthin might be useful and might be a good substitute for the beta-carotene especially, because we noted at the time we did this study, the first ARED study, that beta-carotene at that high dose was dangerous actually in smokers. It could increase the risk of lung cancer in patients. So it really didn't make sense to be giving that high a dose of beta-carotene. So the other knowledge that had occurred since the start of the first ARED study, is that new epidemiology had come out from one of my mentors, Dr. Joanna Sudden, who had done a study looking at lutein and zeaxanthin intake and found that people who had a good vegetarian diet and were eating 6 milligrams of lutein per day had a much lower, about a 40% lower rate of macular degeneration compared to the people who were eating the usual amount of lutein and zeaxanthin that we consume in our diet, which is just 1 or 2 milligrams per day. So this strongly suggested we should be studying the carotenoids even further. And why are carotenoids important? And why are lutein and zeaxanthin important? Well, I've been talking a lot about the macula, but the macula is only part of its name. It's the macula lutea, the yellow spot. So we consume lutein and zeaxanthin from our diet, from green leafy vegetables and orange and yellow fruits and vegetables, but they are concentrated right in the macula, very specifically, and it's only a few of these, and even though there are many carotenoids in nature, only lutein and zeaxanthin and some of their metabolites are found in the macula. And this is a cross-section through a monkey retina here, and you can see right in the foveal pit, this is the vitreous down here, it's visibly yellow from the amount of dietary lutein and zeaxanthin that gets into the retina. And these act as light screening compounds and antioxidants. And they form what's called the macular pigment, again shown here. And that's concentrated by specific binding proteins in the inner retina here, where they act as both antioxidants and act as light screening compounds in the retina here. And we talked about light. Well, they absorb. Blue light is the most hazardous light that we are routinely exposed to. That's why when you wear sunglasses, most typically they're yellow-brown because they're absorbing blue light. And carotenoids, and this wavelength, this hazardous wavelength, is in the 460 range. And the carotenoids, lutein and zeaxanthin, absorb very well right in this range. They let the longer wavelengths pass through without much problem. They also not only seem to be protective against macular degeneration, but they may even enhance visual performance by acting again as yellow filters and decreasing glare, decreasing chromatic aberration, and enhancing contrast sensitivity. So they even have a functional effect that may have been selected through natural selection through all the years, more than macular degeneration, because macular degeneration is a disease of the elderly. So my laboratory is dedicated to trying to understand how and why carotenoids get into the retina. And this is a very specific process. As I mentioned, there's over 600 carotenoids in nature. They're responsible for many of the plant pigmentations that we have out there. And how do we go from just 600 down to 2? Well, we don't consume all carotenoids in nature. Only about 50 are actually in a normal diet, normal human diet. So there's some selectivity right there. The next selectivity occurs in the gut, where not every carotenoid is absorbed. Only about 15 or 20 of these carotenoids are actually absorbed from the gut into the bloodstream. And then these are deposited generally through most other tissues through the body, but only lutein and zeaxanthin actually make it into the macula. And this has to do with the fact that there are specific binding proteins that are designed to pick up lutein and zeaxanthin. I don't have time to go into the basic biochemistry of that, but that's the kind of work that we do in my laboratory, is isolating and understanding these proteins that are involved in the uptake to get them into the retina. So this is why, in terms of supplementation for macular degeneration, we really want to focus on just these 2 carotenoids. So where do we get them? Where do we get them from our diet? Well, lutein is reasonably common in an American diet. We consume about 1 or 2 milligrams per day. And they come from dark green leafy vegetables, orange, and things like egg yolk. And so you can see a vegetarian, if they eat just 100 grams of spinach per day, is getting a pretty hefty dose of lutein every day. If you eat kale, it's even higher. But you can just see how poor the American diet is, in that only 1 to 2 milligrams is actually what most Americans consume. They are very safe compounds. The European Food Safety Administration considers about 75 milligrams to be a safe dose of these compounds to be consuming each day. Most of the supplementation trials that I'll be talking about, such as AREDS2, look at about a 6 to 10 milligram dose, because that's about saturation in terms of uptake into the body. But it's well above what a normal American would be eating, but it's certainly at a safe range. Zeaxanthin is much less common in our diet. We only consume about 2.2 milligrams per day, coming in from either corn, egg yolks, or yellow or orange peppers are actually pretty good. The acceptable daily intake is still pretty good, about 50 milligrams per day. And most supplement studies are looking at 2 to 6 milligrams per day. And there's a third carotenoid found in the retina called mesozeaxanthin, which is a metabolite of lutein. This one we never consume in our diet, unless you have a diet that's high in fish scales, shrimp shells, or Mexican eggs. That's the other source too. And maybe you get that here in Texas, but at least we don't. In Utah, we don't get Mexican eggs. And this is because it has to be made from lutein, and this is made just by a commercial process. But very interestingly, in the retina wants more zeaxanthin, and it seems to be producing from lutein. It's making its own mesozeaxanthin. And one of the projects currently in my laboratory is to figure out the enzyme that's involved that's doing that process. It's still unidentified what that enzyme is. But you can already start getting supplements of mesozeaxanthin because it's relatively easy to make in an industrial process. The problem is we don't know if it's totally safe and if it's more effective than regular zeaxanthin. And because normally you don't have it in your bloodstream, we don't have it in our diet. So it still needs to be studied more. But there is, the deposition into the retina is very specific for all of these, for these lutein, zeaxanthin, and mesozeaxanthin. The concentration in the macula is almost 100-fold higher than what there is in the serum. It's just very, very high. And it changes, so in the blood and the liver, the lutein to zeaxanthin to mesozeaxanthin ratio is 3:1:0. But by the time you make it to the macula, where it's very highly concentrated, it's 1:1:1. So this shows there's a lot of metabolism going on, a lot of specific uptake going into the retina. So that's kind of the basic background of these compounds. And so using the knowledge that lutein and zeaxanthin were very important, but we really didn't know much about mesozeaxanthin about 10 years ago when we were forming the AREDS2 study. We took the original AREDS formulation and wanted to test whether lutein and zeaxanthin are better than beta-carotene. And we also decided to test omega-3 fatty acids. And we looked at AMD progression, cognitive function, cataract development. And as I said, there are about 4,000 patients. I was involved in the study. We enrolled about 60 subjects. And we announced the results just about a year and a half ago. And the way that we took the patients is these 4,000 patients were randomized to get either control supplementation with just a basic AREDS formulation, or lutein and zeaxanthin in a 10 milligram and 2 milligram dose, EPA and DHA at a 1,000 milligram dose, or they got everything. And they then compared these different groups to see if they could see a positive result. And that's what's called the primary, that was the primary randomization. And shown here is that there was not much difference between placebo and AREDS, or the AREDS formulation and placebo. And actually DHA did nothing here. That's shown here in here. And there was only a small improvement with the lutein and zeaxanthin. It wasn't enough to call it a positive result, although it was suggestive. But when we reanalyzed the data even more, we realized that the beta-carotene was probably interfering with the lutein and zeaxanthin uptake. So once you compare to the patients who got AREDS with beta-carotene versus the ones who got lutein and zeaxanthin, the difference started to become clear. We got about a 10 to 20% improvement by getting rid of the dangerous beta-carotene and putting in the lutein and zeaxanthin. So we were able to show that there was an improvement that could be made. And so considering the safety and the efficacy, we came up with an AREDS2 formulation that replaced the beta-carotene with lutein and zeaxanthin. And that's now currently the standard of care. So the AREDS2 formulation now that I recommend to my patients to slow down progression of macular degeneration is to continue taking the vitamin C at 500 milligrams, the vitamin E at 400 international units here, and to get rid of the beta-carotene and instead put in lutein at 10 milligrams and zeaxanthin at 2 milligrams. We still continue the zinc at 80 milligrams and the copper here. And unfortunately, the omega-3 fatty acids did not pan out. So we don't recommend additional supplementation of omega-3. But we still recommend a good diet with fish. That still is important. So what else is on the horizon? Well, a lot of my patients talk about herbals and want to know about that, other botanicals that they can be taking. And I'm always willing to learn from my patients, but I have to tell them that the science may not have already caught up with them. So a number of them ask about bilberry, which has long been known for decades, has been promoted to promote dark adaptation and maybe to prevent macular degeneration. And these blueberry-like compounds have a lot of antioxidants here, shown these polyphenols. But unfortunately, there's no prospective studies. That's still something we need to look at the extracts, what's actually in bilberry, which might be the active compounds, which are found in the retina, which can actually have a positive effect. So it's still, the science is still out on that. The jury is still out on that. Another compound that some of my patients ask about is resveratrol, the compound in red wine. And just like in cardiovascular disease, There is some protective effect if you consume a glass or two of red wine per day. People are looking at resveratrol, but as you know, those of you who study resveratrol, to get an effect, you need to take enormous doses. It's much more than a glass of wine. It's like 200 glasses of wine a day. So that, again, studies still need to be done, but it's another interesting antioxidant. There's eyebright, which is another compound that we're not even sure what's in it, but some of my patients swear by this, that it helps them see better. Clearly, marketing was very good. It has a great name, so people remember it as eyebright, that it helps their vision get better. But again, that's something for those of you who are interested in natural products, that may be something to look at and really learn what might be in some of these compounds that seem to be helping eye strain, macular degeneration, etc. But we do know that sometimes natural medicine gets it right. In Chinese traditional medicine, there's something called wolfberry or goji berries, which are shown here, is made into a tea, has long been, probably for centuries, been promoted as being useful for the eyes. And this is consumed as either dry fruit or tea. But this is actually one of the best sources, and people are looking at this as a commercial source for zeaxanthin. We've just talked about how zeaxanthin is very important, and this is where zeaxanthin can come from in commercial amounts. So it does show that traditional medicine can get this right. So what do I recommend patients, just as I sum up here? I still emphasize diet as the #1 thing to do, especially in the worried well, the children, grandchildren of macular degeneration patients. They're asking me, should I be taking supplements? The answer is probably not. We haven't proven that taking high doses of lutein and zeaxanthin, omega-3 fatty acids, makes a difference. But there's a lot of good epidemiology data suggesting diet is important. And if you're at a young age, changing your diet is at least easier. But it becomes very difficult if you're going to be 70, 80 years old and trying to tell someone, start eating 6 to 10 servings of fruits and vegetables per day, when they haven't been doing it all their life. They're just not going to change. That's where supplements come in, and that's where taking an AREDS type supplement, an AREDS 2 type supplement with 10 milligrams of lutein and 2 milligrams of zeaxanthin is very important. The other supplements that they ask about, things like mesozeaxanthin, herbals, I have to say they're just on their own. We really don't know if that will make a difference. Alcohol should be consumed in moderation. Obviously, they shouldn't smoke. They should avoid excessive light exposure. Wearing sunglasses is very important. And certainly I appreciate that many of my patients were willing to volunteer to be randomized to all these different nutritional supplements and join AREDS 2. If there's ever an AREDS 3 study looking at mesozeaxanthin, looking at extracts of eyebright or whatever you can say, I certainly will appreciate if they join that again. So I would like to finish up here. And this is where I work at the Moran Eye Center. And thank you for having me here. Any questions at all? I'm sorry, why do Mexican eggs have? Okay, and that has to do with the fact that the manufacturers the Mexican population likes apparently a very yellow-orange egg yolk is preferred in consumer preference. And by having a higher zeaxanthin supplementation, that lutein and zeaxanthin, let me put it back, let's take a step back. Lutein and zeaxanthin are added to chicken feeds to enhance not only chicken color. So in the East Coast, I don't know if you have Purdue chickens here. Is that a brand that you've heard of? But Purdue chicken, if you go to the East Coast, chicken is very yellow there, just in the market. People like it that way, and they've learned that by supplementing with carotenoids, that can make a difference. It also colors the egg yolk, and it depends on which carotenoid you use, what color you get. And the color preference apparently in Mexico is to have it a little more orangish, and so high zeaxanthin. And it's hard to make zeaxanthin commercially, but it's easy to make mesozeaxanthin. So mesozeaxanthin is manufactured in Mexico, put into the Mexican chicken feed, and so that's where it is. It has not reached, it's not used in the US. We've checked the chickens that we're looking at chicken eggs for other reasons in my lab, and we check the carotenoids, and it's strictly lutein and zeaxanthin, and those are Idaho chickens. So we're far enough from Mexico. So that's the difference. It's just the preference there. Yes.
You said earlier that blue light was the most hazardous.
Mm-hmm.
Why is that? Isn't blue light what kind of triggers melatonin breakdown?
So it does. So blue light is involved in the melanopsin. It does. It's very important in the circadian rhythms. But it's also the most energetic light that we are routinely exposed to. So that's more likely to cause oxidative damage to the lipids and other structures in the retina. So that's what we consider the blue light hazard. And in light damage models, it's definitely the wavelength in mice and other animals that causes the most trouble. Okay.
So
Yes. Oh, sorry.
It's because of the oxidation.
That's what we think. Yes, in the back.
So what contributes to leakiness of those blood vessels that get in there?
Okay. So the question is, what contributes to the leakiness of the new blood vessels? It has to do with the fact that when abnormal blood vessels grow either in diabetic retinopathy or in macular degeneration, it's an abnormal process driven by a compound called vascular endothelial growth factor, VEGF. And this promotes, in an imbalance when there's too much VEGF, the blood vessels don't mature properly, so that they're more fenestrated and more leaky, and they kind of lacy. They just are pathologic blood vessels. So one of the ways that we combat these leaky blood vessels is to knock down vascular endothelial growth factor. That's what the drugs are. But they're also looking at growth factors like platelet-derived growth factor, or pigment epithelial-derived growth factor is the one, that if you give that promote vascular maturity, again, if you can make them so that they're less leaky. So that's another new generation set of drugs that are coming in. Yes? Yeah.
How exactly does beta-carotene interfere with lutein and zeaxanthin uptake?
Okay. So with beta-carotene is a carotene, so it's not a xanthophyll. Xanthophylls are hydroxylated once or twice. That's why lutein and zeaxanthin have no vitamin A activity. But the process, especially in the gut, is driven by, there are transporters. I didn't talk about those. Things like scavenger receptor B1, CD36, that are involved in carotenoid uptake. That carotenoid uptake in the gut is it's a relatively promiscuous transporter. It takes a lot of different carotenoids. It's not like the specific binding proteins. So not only are they competing for the transporter across, but high doses of vitamin A, of beta carotene, will then, through feedback mechanisms, through a protein called ISX and several other proteins, will then drive down the levels of scavenger receptor B1, drive down the transporter. So there's a feedback loop. If you have too much of one carotenoid, it can then drive down the whole uptake process. So it's complicated. We're just understanding it, but there's enough similarity between the compounds and their uptake mechanism from the gut that's where the competition comes through. And in the AREDS2 study, we found that indeed the patients who were given on high-dose beta-carotene and high-dose lutein had much lower lutein and zeaxanthin levels than those who were not given the high doses of beta-carotene. So the actual competition problem does definitely show up. Yes? Okay, so yeah, okay. I think that I think a balanced diet with a good mix is good. So I think that goji berries and carrots would be a good combination. So I don't think it would be a big problem. We really we're more worried about, at least in the nutritional ophthalmology field, we always at least have to think carefully about high doses of a single compound. And of course we have to worry about it even with lutein and zeaxanthin, but that's the one we have the biochemistry to support going in with those high doses. When it comes to food, I think it's harder to overdose on any particular carotenoid. I think you're getting a good mix no matter, everything. None of these are pure sources anyway. There's going to be beta carotene mixed in with the lutein and